Good morning, everyone. Thank you for being here this morning, and I'd like to thank the organizers for inviting me to give this talk. I will be speaking about disparities in lung cancer screening and low-dose CT access. These are my disclosures. The objectives of my talk will be focused around understanding the burden of lung cancer mortality and the impact of lung cancer screening, understanding disparities that exist in the lung cancer screening space, and the barriers that limit equitable access, recognizing the populations at risk, in particular patients of the underserved communities and those with socioeconomic disparities, and then strategies to help improve uptake and access for lung cancer screening. So I'll start off with a case presentation because really I think that highlights a lot of the different areas that we could work on. In clinic one day I saw a patient, 62-year-old patient of African American origin, 40 pack year smoking history. He quit about 5 years ago, lived in a semi-rural area out of the urban community, had Medicaid insurance, did not have a primary care physician, and he presented with cough and weight loss for about 6 months to the emergency room. And workup and testing concluded with a diagnosis of a stage 4 non-small cell lung cancer. So pretty standard, unfortunately. We all see these patients in clinic, but if you take a step back and you start thinking about, could this have turned out differently? Could we have picked this up early? Could this patient have been diagnosed earlier? And you look at it, he falls within 50 to 80 years of age, the current eligibility. He smokes more than 20 pack years, so about 12 years ago, he would have been eligible for lung cancer screening. And if he potentially had annual lung cancer screening with a low-dose CT scan, hypothetically speaking, you could have detected this, identified an early lung cancer with much favorable outcomes, right? The fact that he did not have a PCP, another barrier, Medicaid insurance, access, lived in a rural community which was far from a lot of the centers. So I think that begs to ask the question, what can we change and what can we do? And sort of that's how I think I got interested, because I am on the other end of the spectrum. I'm a thoracic oncologist. I treat these patients, but then it also helps you understand what we can change. And in this particular patient, we had patient-level barriers. The patient did not have a PCP, was not aware of lung cancer screening. We have sort of provider level. If he had a PCP, a lot of the patients state that at least 50% of patients, based on what we found in our community, did not recall having discussed low-dose lung cancer screening with their providers. Access and system-based barriers become issues. Patients that are in rural communities, transportation barriers, having to take the day off just to get a screening study, that can be a barrier. And then, of course, inherent racial and socioeconomic barriers. And so, with understanding all of these, I think I want to take a step back, zoom out, and look at what the impact of lung cancer is on our communities and what's the improvement. And we know that lung cancer is has the highest mortality of all cancers and contributes to the highest cancer mortality in general. And improving lung cancer screening by a low-dose CT scan. And this is back in 2011, the New England Journal of Medicine. We saw the results of the NLST that showed that a low-dose CT scan in a high-risk population improves lung cancer mortality by 20%. In the Nelson trial, which was almost 9 years later, showed about 26% in a high-risk population. So, overall, a 20% or higher mortality improvement with lung cancer screening. The current guidelines, as you know, is 50 to 80 years of age, more inclusive because they include 20 pack years and not 30, and patients who quit in the past 15 years. So, it's been 13 years since USPSTF have approved lung cancer screening. And so it's really impressive, 13 years, and CMS approved 2015, but our rates remain in single digits. If you look at the National Health interview survey or the BRFSS survey across the country, the most recent one in 2023, you can see here that 67% of patients eligible for colorectal cancer screening actually get screened. Almost 80% get breast cancer screening. This is the percentage of eligible population. And 75% get cervical cancer screening, those that are eligible. But when you get to lung cancer screening, the rates historically have been in single digits. 3%, 4%. Most recently, based on the American Lung Association estimates, the rates have improved, but still in the teens, and like 15 to 18%. Some states it's much lower. So it's really a very different sort of depth of and layers of disparities that we're looking at when we talk about lung cancer screening. And I think, despite the fact that there is improvement, there's no denying that, we're still at a lower number. And so I think to understand why we have such a big gap and why there is so much, despite 13 years of this data, why are we so behind? I think we have to understand the big core components of a lung cancer screening process, and it's a little more, not as much streamlined as colorectal cancer screening or cervical cancer screening. Lung cancer screening involves a very structured referral system. It requires a primary care physician, it requires a pulmonologist, in some cases a oncologist in rare cases, and then a radiology center. And then, of course, there's a lot of navigation in between all of this to make sure the patient doesn't fall through the cracks. A comprehension patient coordination system, multidisciplinary collaborative approach. That patient has a nodule, who do they go to? What does the pulmonologist do? Is there a biopsy that's needed? There's a lot of steps in those. And then the standardized reporting system also, these scans have to be read in a certain way, and so that also requires a separate sort of educational structure behind the radiologist reading it. And so, of course, with all of those things involving, the barriers are just innumerable. But I think, the three different ways we can sort of structure these barriers is really system-based barriers. And these are things that we can potentially fix. And then I think I like to say physician-perceived barriers, because some of them are more perceived than they are. They did a survey across the country, and they surveyed primary care physicians, and almost half of them thought that several insurances still didn't cover, or there was a prior auth requirement for each of these patients because of their experiences. So that creates a lot of perceived barriers. And then sometimes there's implicit bias also within these patients. And I think the patient-perceived barriers is another space we can work on, and that is lack of awareness, improving awareness within the patient population, understanding why they need a test even though they feel fine. And then the logistic barriers, which is also financially what we can help with, smoking-related stigma, fatalism, which is real, and then mistrust in the healthcare system, which also can be, I think, improved by community outreach events and really building local champions. So again, in addition to all of these disparities, the other thing we have to understand is there are also inherent disparities in each of these communities. The patients with socioeconomic status, with gender disparities, LGBTQ disparities, age, rural, any racial and ethnic. So healthcare disparities exist within all of these communities, and then on top of that, you add the complexity of the lung cancer screening based, and it just really creates, quite a challenging path. So, again, just looking at, particularly in the field of lung cancer, we see disparities in outcomes in the treatment process, but at the same time, if you look at diagnostics, patients of underserved or minority communities have lower rates of early diagnosis than patients of Caucasian origin. And so, just going, very briefly talking about even the educational and the financial status. So studies have shown that patients that live below the federal poverty level have lower rates of lung cancer screening, and in particular, patients that have a lower educational level, lower than a high school diploma, have lower lung cancer screening rates. And that in itself adds on, because both of these populations also have high smoking rates, so they're probably more eligible but less screened, right? And so, sort of going back to our case again, you're talking about so many disparities here: patient with the ethnicity, with living in a rural population, to not having a PCP, and so we sat down and thought about how we can help improve this in our state. So I am from the state of Rhode Island, and so we started a study in collaboration with a community, large primary care practice, Blackstone Valley Community Health Center. And our study was funded by Robert Wynn, a diversity award program, and we decided to implement a community-based navigational program, identify the barriers and challenges that exist in our community, and see how the navigational program can help improve the outcomes here. And I'm going to try to stick to our timeline, so I will try to be brief here. But the two main areas that we focused on, three areas, were awareness, patients, and even providers, improving awareness and education, access, resolving gaps by one-to-one navigational support within the patients and the navigator, and then creating these outreach events and community champions, because what we saw was that in certain cultural communities there were a lot of mistrust or potentially biases, and having these local champions really helped improve uptake and adherence for lung cancer screening. So, again, our patients were eligible patients that would have been eligible for lung cancer screening. We intervened in the year 2022 and 23. A trained patient navigator was integrated into the lung cancer screening process within the whole community, and her job include really logistic support, education, and helping through the entire process for lung cancer screening. And one major component of this was identifying the patient barriers and identifying the demographics across these eligible patients and those that had actually done cancer screening. And one brief thing that I would like to highlight here, so this is, we had about 2,900 eligible patients, and about 400 of the, close to 400 of them had low-dose CTs done. When we looked at the demographics in the two populations, the one thing that stood out is that even though this was an underserved minority population, 70% of patients that completed the low-dose CT actually spoke English. So, higher English-speaking patients and those actually completed low-dose CTs, and then about 60% of those that did not undergo lung cancer screening, the entire eligible population, 60% were English-speaking, and higher percentage of patients that completed low-dose CT scan were white and not of a diverse background. So even in our population where we had this navigator instituted, these barriers continued to play a role, despite having the navigational support. And this thing, I find it very interesting, and I urge all of you to look within your communities to try and find the barriers that exist, because each community has a different set of barriers. And I think in our potential, what we found is about 60% of patients said they did not speak to their PCP at any point about lung cancer screening, or I say they did not recall because maybe they discussed and they just didn't remember. 45% were not aware it was covered by healthcare insurance, and in our population, 46% did not know that there was something called a lung cancer screening. People know breast cancer, colon cancer, but they did not know. So the awareness remains a big issue, even in 2023, 2024. And so just very briefly, what we saw is that in 2020 and 2021, prior to the navigator, in our underserved population, the lung cancer screening rates were 1.5 and 2.9% respectively. And then with the institution of the navigator, we saw the rates increase to about 12%. Now again, that's still 78 or I guess 88% lower than what it should be, but it's an improvement, and we know that the navigational support works. In 2023, it was 12.6%. And here's the other important thing, primary adherence. Once they get a low-dose CT done, a lot of them fall off, and adhering to the process and following up, almost 40 to 50% of them actually had adherence with the navigational support. So I think to conclude, identifying barriers, and in our case, lack of patient awareness remained a major barrier. Implementing a navigational program demonstrated not only increase in lung cancer screening rates, but also adherence. And also highlighting the fact that, in our population, we had a higher proportion of English-speaking patients in the low-dose CT completion cohort group, highlighting that language barrier still plays a role despite having translators and interpreters within the system. So, this is just from our experience within our community and with our study, this is sort of what I think are the 2 or 3 major components: access, awareness, focusing on those, and community outreach, really getting to the patients and then helping them come. And again, these might be different for all of yours. For some places that are, like say in Utah or South Dakota, they may benefit really from a mobile low-dose CT scanner, because that comes with its own caveats. But I think in the right places, this could really do what you need it to do. health system interventions like EMR tools, they really can make a big difference in identifying the patients and creating those reminders for very busy primary care physicians that have a laundry list to discuss. And then risk-based screening models, in communities where there are patients that are of higher risk populations, you know already that are under screened, then implementing risk-based screening models. And then patient navigation, I think across the board really helps. And I urge all of you to start by identifying the barriers that exist in your communities and seeing how you can improve that locally and then implementing across the system. Thank you.
I'm going to be talking about Kaposi sarcoma, and it's kind of a weird thing because I realize that many of you in this room have probably never seen a single case of Kaposi sarcoma. But when I started my practice, which was in the AIDS epidemic area, I had a very focused HIV practice, and I would see at least 10 patients with devastating KS each day in clinic, and I'd see about 5 patients with AIDS-related lymphoma. And so to get from where we were to where we are now is really something. But I really want to stress on you that KS is a huge problem globally, and in particular and dominantly, as we'll see, in sub-Saharan Africa. My talk of 15 minutes is going to be broken down into these individual areas. And at the end, we'll talk about barriers to care as well, and maybe some things that could be done a little bit better, particularly as we think about implementation science. I have no disclosures to announce. I do get a grant from the AIDS Malignancy Consortium, which is funded by the NCI. So the disease burden for Kaposi sarcoma is really reflected in this slide right here. And 73% of the cases worldwide are in sub-Saharan Africa. Roughly 80% of HIV-associated KS, which is really the dominant thing and what we're going to be speaking about today, is in sub-Saharan Africa. The difference between high and low middle income countries is substantial. And as I said, these days, I've seen dermatologists who are new to their practice, who've been in practice for the last 5 or 10 years and have maybe seen 1 or 2 cases. And in each instance, when it's diagnosed, it's been on a biopsy, not because of what they recognized from their training. In low and middle income countries, though, this is a profound and important problem. And again, this blow-up slide just is there to illustrate the challenges associated with the distribution of KS, particularly in sub-Saharan Africa, where it's the 2nd or 3rd leading cause of cancer and a leading cause of cancer mortality, even though in the US and with ART, we think of this as a really quite benign process or potentially benign process. As I kind of alluded to, the clinical spectrum of KS is diverse. In the US and with ART, I usually see just patients who have a few pigmented skin lesions, not necessarily even noticeable, not always needing or requiring treatment. But in areas where we have poor access to antiretroviral therapy, KS proliferates and grows, and particularly in the context of immunosuppression. And with HIV, the incidence is 100-fold higher. And in those areas of the world where KS is a problem, the clinical spectrum is very different. Patients die from KS. They develop huge issues with lymphedema. Sometimes they require amputations. And the stigma associated with KS, which was very real in the US in the 90s and the 2000s, is very much a process of people with KS in those areas of the world. In all forms of KS, HHV is the cause. And so just like we'll learn from Dr. Goff that HPV is the cause of cervical cancer uniformly, so is this virus, HHV8. And when we think of what are the differences regionally, I was impressed when the AIDS epidemic did hit India. There were very few cases of KS. And that really depended on the difference in HHV8 seroprevalence. And you can see in the US it's about 3 to maybe as high as 10% in some communities. But in sub-Saharan Africa, it's 30 to 90%. And that the lack of availability of ART and the seroprevalence directly correlates to that blow-up map you saw showing the incidence of Kaposi sarcoma. So as we talk about this, the difference between high and low income countries is enormous, and it can be broken down in the next two sides. In high income countries, case burden is small, the disease is usually indolent, and it usually responds to just antiretroviral therapy alone, and episodically, KS may be needed to push things further. In low and middle income countries, patients are presenting kind of as Dr. Khan mentioned with lung cancer at a late stage of disease. There's a lot of stigma associated with it. There are a lot of barriers to getting to a medical center, challenges with diagnosis, things I'll discuss in a little bit more detail in a minute. But those patients are presenting with life-threatening disease. And usually for them, they do require chemotherapy as a primary component in conjunction with ART. These patients will present uniformly with low CD4 counts, so their immune system is more compromised when they're diagnosed, and they have much higher HIV viral loads, which again impact the pathogenicity of this cancer pretty profoundly. I can't overstate the benefits of antiretroviral therapy for this viral-induced malignancy. And it's really an essential component of KS therapy. I love this slide for one reason, and it's this picture right here. This is, if I go back one, this is the same person. This was before antiretroviral therapy was available, and then after he had been on HIV medications for 2 years. And I want to point to you that he has a daughter. If you are undetectable with HIV, you're presumably not transmissible. And so this person on the left is the same one right there. And so I think a really worthwhile photo to kind of drive that notion home of why antiretroviral therapy is important. And I'll also talk a little bit about why some of the changes in government and the way that we are becoming insular in our support of third world countries is going to have such a big impact in sub-Saharan Africa and other areas of the world where HIV is a huge problem and where they depend on the US for ART. So if we talk about barriers to care, suboptimal ART coverage is huge. And in sub-Saharan Africa and other areas of the world, ART availability has improved substantially. But we're kind of running now into an existential threat as the United States is failing to fund things like the World Health Organization and PEPFAR and other organizations really which were developed to getting ART in a very structured fashion into the, low and middle income countries. Additionally, ART adherence is a challenge. It's a challenge in the US too, although that's improved because here in the US, for most people, it's one pill once a day, and most people can manage that. And now we have long-acting injectables where a patient could come into a clinic and get a shot once a month or once every 2 months. And that's going to make a big difference for those patients who are really challenged and just can't get it together to take that one pill a day. In Africa, there's so much stigma associated with HIV. The challenges of keeping medications, not forgetting to take it, having them available in a wide and uniform distribution remains a problem. So even though KS rates have gone down and plummeted in the US, in sub-Saharan Africa, they've gone down a little bit, but not a lot, and this remains a huge problem. The US political, the climate in the US is clearly an issue and will become a further issue if we stay on the direction that we're currently moving with in our current administration. So NCCN guidelines and Infectious Disease Society of America indicates that liposomal doxorubicin is a preferred drug along with paclitaxel. The AIDS Malignancy Consortium did a trial years ago comparing Taxol to liposomal doxorubicin. They were equally effective, but you didn't have alopecia, and you didn't have neuropathy, and you didn't have mucositis with liposomal doxorubicin, which doses are a little bit lower than one might use or expect with breast cancer. The indications are anyone whose KS is not responding to antiretroviral therapy, and for those who have advanced disease, it requires systemic chemotherapy in conjunction with ART. In the absence of ART or with ineffective ART, antiretroviral therapy, response rates are about 45 to 70%, but when it's combined with antiretroviral therapy, that goes up to about 90%. And certainly, even if it doesn't regress completely, it shrinks very profoundly. So I guess in the US, our standard is liposomal doxorubicin, and there are challenges offering liposomal doxorubicin in areas of most need. One is cost and availability. Pegylated doxil or liposomal doxorubicin costs about $180 a cycle, which is unwieldy and not possible in sub-Saharan Africa. Additionally, these meds, including paclitaxel, require pre-medication. And many of these areas in greatest need don't have the infrastructure for a Benadryl, for a hydrocortisone, for a careful administration of drugs. And so in Africa, a commonly used regimen would be bleomycin and vincristine, which requires no medication and is relatively treated. Oral etoposide, a drug often used for, or used to be used for lung cancer, is also available. So the AIDS Malignancy Consortium did a landmark trial where they compared paclitaxel to the two alternatives. And what you can see in this slide was that there was a dramatic benefit to paclitaxel in this context. More efficacious, less toxicity, and with the conclusions of this group was that paclitaxel should be the preferred drug in sub-Saharan Africa, and it's on the WHO list of essential oncologic drugs. The AMC also called out for a financial analysis, and in 2022, a Lancet article showed that paclitaxel was highly cost-effective. The impact on saving in lives was dramatic. But there are clear barriers to implementation. It requires a cancer care infrastructure. There needs to be trained personnel to give it. And the budget that would require is probably pretty small, but still significant when we think about the budgets for health. I think, I looked at something last night, and in Nigeria, there are something like 60 oncologists in the entire country. And in many of the sub-Saharan countries, it's much less than that. And so we don't have subspecialists there to really do it. So in the absence of time, I'll move through this pretty quickly, but these are significant barriers to care in low and middle income countries. And, when we think about all the diagnostic things that are needed, pathology, the ability to safely administer chemotherapy, the implementation science is really a significant issue here, even though a drug like paclitaxel is very, very much a benefit. There are a lot of emerging therapies, but the challenge is how to keep them cost effective. Dr. Badia has done some amazing work looking at low doses of immune therapies like pembrolizumab, which have real potential for benefit in this context and which could be given in a safe way. Nivolumab and Pembro are now NCCN-guided recommendations. They are available. They're not commonly used, usually, at least in the US, where we have such great benefits with liposomal dox and ART. Pomalidomide is also FDA approved, but again, the challenges of rolling this out in a cost-effective way in sub-Saharan Africa are large. And, you know, as we think about the toxicities of checkpoint inhibitors, that's clearly going to be a barrier too. And also the need and understanding of how to treat immune reactions. So there remains a significant gap between high-income countries and low and middle-income countries. Again, 5-year survivals are outstanding in the US, but they're dismal in sub-Saharan Africa. It's about 45% over a 5-year period. And even as we've evolved where, you know, originally there were set standards for when we would roll out ART, usually when patients' CD4 count fell below 350. We now have that where everyone should get treatment up front. And that hopefully will make a difference, but it hasn't had a big impact yet just because of the difficulty of democratizing antiretroviral therapy. So here are some of the recommendations that would make a difference. An easy one would be to expand access to paclitaxel. Hard to do, but improve the cancer care infrastructure, make diagnosis on the early end of the spectrum rather than on the late end of the spectrum. And really the research needs are to develop cost-effective treatments, implementation science to get paclitaxel to the most amount of people with the least amount of pain, and strategies for early KS diagnosis. And again, I think there's a real, not just existential threat, but as the US begins to contract fairly dramatically in our commitment to world health, KS is going to mushroom and be a huge problem, as will the reemergence of AIDS in a very profound and significant fashion. So I'll conclude with these bullet points. And what I've tried to make a point to you all is that there's still significant gaps in care between high and low and middle income countries. In high income countries, it's rare. Many of you have probably never seen a case of KS, but in low income countries, it's a huge problem, and mortality remains high. Now, I have one last slide, and I'm gonna go right to it, and I'll skip my conclusions for now. Anyone who is a subscriber to The New Yorker cannot partake in this. But if you know The New Yorker, there's a little cartoon at the end of the segment, and they ask you to give or vote on the best or provide a best caption for it. So this was a cartoon a few months ago, and you can see, I don't need to describe that cartoon to you. So I'm going to ask you which of the three was the winner for this cartoon. And yet he still bites at a rubber worm. That's one caption. I thought legs would come first. And the third being, obviously, the light is better up here. And so with maybe a show of hands, I'm going to ask for number one, how many people think that should be the winner? We got 1, 2, okay. I forgot legs would come first. Whoa, okay, that's a biggie, all right. And this is the last one. Obviously, the light is better up there. Okay, I think it's pretty close between 2 and 3. Number 3 is the winner. All right, well, thank you for your attention. And now I'd like to introduce Dr. Barbara Goff, who's going to speak to us about HPV and the importance of HPV screening and the impact of HPV in low-income countries. Dr. Goff is a professor of medicine at the University of Washington. She chairs the OB/GYN department. Her focus, obviously, as an oncologist, is in GYN malignancies. She's written extensively about treatment of gynecologic cancers. She's had a significant focus, her work in ovarian cancer, and she also has done a lot of work, I thought it interesting, on the effects of COVID on pregnancy, and has looked at a big portion of her career looking at disparities in care as they pertain to GI malignancies. OBGYN malignancies. If we could give a warm welcome to Dr. Barbara Goff.
So I'm going to talk about HPV virus-induced malignancies, and really what I want to focus on is screening as well as prevention, because many of these cancers are completely preventable, and you're going to hear some of the efforts that the World Health Organization is doing to try to eradicate cervical cancer, because they believe that is within reach within the next couple of decades. First, I want to say I have no relevant financial relationships to disclose. There we go. So let's talk we'll back up to basic biology. How does HPV actually cause cancer? Well, almost all of us get infected with HPV virus at some point in time in our teens, 20s, early 30s. For most of us, we'll have the virus and it'll last in our system for about 18 to 36 months. And then our immune system will clear the virus and we're never bothered by it again. But a small portion of individuals will contract the virus. It will not be cleared by the immune system. And then the virus will integrate into the host cells. It'll start producing E6 and E7, which then impact both P53 and RB1. And with the knockout of those tumor suppressor genes, this allows unregulated growth and tumors can progress from pre-invasive to actually invasive cancers. So HPV has a huge burden of disease when it comes to cancer. So it's estimated that over 830,000 people will contract an HPV-related cancer, and there'll be over 400,000 deaths. There is a huge gender disparity in terms of HPV-related cancers. So you can see here the split of cases. 736,000 women will contract HPV-related cancers compared to about 95,000 men worldwide. There's also a significant split in terms of death. Almost 400,000 women will die each year of an HPV-related cancer compared to 44,000 men. So the reason for the huge gender disparity is that cervical cancer is the most common HPV-linked cancer. HPV is responsible for over 90% of cases, probably closer to 100% of cases. Interestingly, oropharyngeal or head and neck cancers are rising rapidly, especially in men. And in this country, now oropharyngeal HPV cancers actually surpass cervical cancers, and we are now seeing more men have HPV-related cancers in the U.S. than we are seeing women, which I think is an interesting sort of turn of events. HPV accounts for about 20 to 40% of oropharyngeal cancers. And then, of course, we have anal, vaginal, vulvar, and penile cancers that are significantly linked to HPV. Now, this is a heat map that shows the global burden in terms of incidence of HPV, which is on the top in blue, and then death rate in the orange and red at the bottom. And you can see there are certain areas, just like the KS cancers that we were talking about, kind of similar distribution, where we're seeing areas like Africa, India, and Oceania having some of the highest incidence as well as the highest death rates. So when we look at geographic disparities, as I said, the high burden areas are Africa and Oceania, which have the highest incidence rates. Asia, actually, because of its size and population, accounts for 58% of the global HPV cancers. And then there is a significant disproportion when it comes to low and middle income countries, just like our KS story. 77% of HPV cancers will occur in low and middle income countries. And when we look at the age-adjusted incidence rates and death rates, in the highest areas, it's 77 is the incidence and 52 deaths per 100K. In North America, it's 20 and 6 per 100K. And in the lowest areas, which would be the Middle East, it would be 5 and 1 per 100K. So you can see there's huge amounts of disparity when it comes to geography. And these disparities are really driven by countries with high human development indices having established screening and vaccination programs for early detection and prevention of HPV-related cancers. And it's interesting, it's been estimated that HPV-related cancers will decrease in Europe by about 4%, but increase in Africa by 105% by 2045. And that's if we don't change our current practices. But as I said, the World Health Organization is very interested in trying to make significant changes. So let's talk a little bit about screening for HPV-related cancers. Cervical cancer probably has the most established screening protocols. We have both pap smear and HPV testing. For oral pharyngeal cancers, it's visual inspection at the time of a dental exam and then biopsy. For vulvar cancers, it's visual inspection and biopsy at the time of a GYN exam. For anal cancers, we now have anal cytology, which is recommended for high-risk individuals. And for penile cancers, there's visual inspection and biopsy in symptomatic patients. So for cervical cancer screening, as I said, we have two options. One is pap smears and the other is HPV screening. Pap smears were actually introduced in the U.S. in 1941, and they have been a very successful modality for screening. It is responsible for about an 86% decline in cervical cancer in the U.S. And other high human development indices countries. And this is despite the fact that it doesn't have all that great of a sensitivity. The sensitivity is only 50 to 80%, and the false negative rate is between 10 and 20%. So it's not a great screening modality, yet it has been responsible for a significant decline in cervical cancers. So we also have HPV testing, and HPV testing was introduced in 1999 as an adjuvant to people who had atypical squamous cells of undetermined significance on their pap smear. Co-testing, which is where you do a pap smear and an HPV test, became FDA approved in 2003. And then in 2014, HPV moved into a primary screening modality where you would do an HPV screen first, and if that was abnormal, then you would follow up with a pap smear. So it sort of reversed the way as it had initially been approved in 1999. Very exciting that self-testing became FDA approved in 2024, and overall HPV testing has a much higher sensitivity, 98%, and then you can see specificity of 87 and positive predictive value of 88%. So it is a better screening test. So when we do an HPV test for cervical cancer, I realize most of you in this room have probably not done an HPV test in your lives, but the provider will collect the cells from the cervix or the vagina. The DNA is then extracted from the cells, it's amplified, and is followed up by hybridization and detection. And then you'll get a report that will report out several things. First is HPV 16 and 18 are each reported out separately. Those are the two highest oncogenic viruses, and so both of those get reported, and you get each of those individually. Then there are 12 other high-risk HPV strains that get reported as high-risk HPV. These are less oncogenic, but still important. The nice thing about an HPV test is it does not require a cytologist, so it starts to bring the cost of screening down significantly. And in the US, an HPV screen just for the test costs between $80 and $150. So as I said, in 2024, HPV self-testing became approved, and there was just a recent meta-analysis in 2025 which looked at HPV self-testing compared to clinician-collected HPV. And what they found was that the sensitivity to detect CIN2 or greater was 74 to 86%, with a specificity of 80%. The self-collection with a mail-in option doubled the screening rates in patients who are not regularly screened. And it is those people who are not regularly screened who go on to get cervical cancer. People who get regular screening, really, it's very, very unusual for these patients to get cervical cancer. And they felt that the slight reduction in sensitivity and specificity was compensated by the higher participation rate. And again, this brings the cost down even further. You don't need a cytologist and you don't need a clinician. And so this is a really important strategy as we think about screening in low and middle income countries. So we also have prevention of HPV-related cancers, and this is where I think there needs to be a much, much bigger focus because most of these HPV-related cancers are 100% preventable or 90% preventable. So I want to go through the HPV history, or the vaccine history with you just briefly. So in 2006, the HPV-4 or Gardasil for girls 9 to 26 was approved, and this targeted 6 and 11, which causes warts, and then 16 and 18, which we've already said are the two most oncogenic HPV viruses. In 2009, the FDA approved HPV for boys. In 2014, the FDA approved the HPV-9 vaccination, which included the original 4 strains and then added an additional 5 oncogenic strains that are a little bit less oncogenic than 16 and 18. In 2018, the FDA approved HPV-9 for men and women up to age 45, which is an important expansion in terms of prevention of cancers. In 2019, over 100 countries had incorporated HPV vaccines into a regular vaccination schedule. In 2020, the FDA approved HPV-9 to prevent oral pharyngeal cancers, and then the World Health Organization estimates their goal is in 2030 to eradicate cervical cancer, and the way that they see the path forward to eradicating cervical cancer is that 90% of girls will be vaccinated by age 15, and there will be HPV self-screens at age 35 and 45, and then 90% of precancers will be treated by community health workers. And so that is the goal of the World Health Organization. In terms of HPV vaccine safety and efficacy, it is a highly safe vaccination. There has been no increase in SAEs compared to placebo in, hundreds of studies that have looked at HPV vaccinations. Immunogenicity is really high, 99 to 100% seroconversion with long-term persistence. Where interestingly, if you get a natural HPV infection, the seroconversion rate is only 50 to 70%. When we look at efficacy in terms of preventing HPV 16 and 18, if you are HPV naive, there is a 91 to 100% protection against HPV 16 and 18. And if it's irrespective, meaning that you've already had sexual debut, you may have been exposed to HPV, the efficacy is 76%. And for preventing CIN2 or greater, again, if you are naive to HPV, there's a 90% protection to CIN2 or greater, and irrespective, there is a 50% protection. So quickly about the dose schedule of HPV vaccinations. When it was initially approved, the initial approval was for 3 doses at time 0, 1 to 2 months, and then around 6 months. And this vaccination schedule proved to be very challenging for people to actually complete. There have been non-inferiority studies in girls less than 15 that show that 2 doses are equivalent in efficacy to 3. So several years ago, the recommendation was to go to 2 doses of the vaccination. And then recently there was another trial looking at 1 dose versus 2 doses in 20,000 girls aged 12 to 16, and they found that 1 dose was as efficacious as 2 doses. And of course, if you have 1 dose, that significantly reduces the expense and really improves implementation. We also know that HPV vaccinations will reduce cancers other than cervical cancer. So the incidence of anal interepithelial neoplasia, there's a 50 to 70% reduction, warts a 90 to 100% reduction, oral HPV infections 80%, and we know that head and neck cancers are significantly reduced in those who've received a vaccine compared to those who haven't. We also see in the US there are huge disparities regarding vaccination uptake. This is from a recent publication in 2022. And you can see that there are some areas of the country like Wyoming, Oklahoma, Mississippi, where less than 50% of people are receiving HPV vaccinations, where in other places like North Dakota, Iowa, New Hampshire, and Massachusetts, where it's over 70, 75% vaccination rate. And as I said, this is one of the most important things that we can do to eliminate HPV-related cancers. So I want to end on what I would consider a huge success story in a low and middle income country. So in 2011, the Ministry of Health in Rwanda, she was really sick and tired of seeing her friends, her family, the people that she loved die of cervical cancer. And so she launched an HPV vaccination program back then with HPV-4. She achieved a 90% vaccination rate that now continues every year with girls age 12, and it's a school-based vaccination program. She also implemented HPV self-screening tests for patients. And they have found that the vaccination in the original cohort, which again, many of these people were already had experienced sexual debut, the vaccine's effectiveness was 52% in preventing CIN2 or greater, and then the incidence rate of cervical cancer is starting to drop significantly in this country. Thank you. So, oh wait, sorry, I have my conclusion. I had something weird on my screen, so I was thanking the person for taking it off. Anyway, so in conclusion, significant disparities for HPV cancers exist, and low and middle income countries have limited capacity for HPV vaccinations, which is prevention, and screening, which would be early detection. But as I said, Rwanda made this work because they really made it a priority. So it is definitely doable. 1 dose of an HPV vaccination before sexual debut is highly effective in preventing HPV infections and HPV-related cancers. And screening for cervical cancer with self-administered HPV tests at age 35 and 45, along with HPV vaccination, does have the ability to reduce cervical cancers by 90%. And then it's important to remember that HPV vaccinations also work for many other HPV-related cancers. So now, thank you very much.
Thank you. I wanted to come off because I have 3 questions, one to each of you. So since I'm first, would you allow me to do that?
Sure.
Yes, okay. So thank you so much, first of all, to the organizers. I am one of those
Can
who...
you introduce yourself?
So my name is Eche Ezanoloe. I'm a professor of pediatrics, infectious disease, and public health at the University of Nigeria. I did spend 25 years here as a tenured professor at the University of Nevada in Las Vegas before I decided to go back to Nigeria. And I went to Nigeria because the president asked me to come back and lead the primary healthcare program in Nigeria, which is the largest health system in Nigeria of 10,000 health facilities in Nigeria. So I went back and I couldn't come back, so I stayed back. So a lot of things that I've seen is having been here. One of my programs before was to run the HIV program for the state of Nevada. So I had an experience running that HIV program for a long period of time. And when we succeeded in no child being infected for HIV in Nevada for 5 years. So going back to Nigeria was to see those things. And here in the US, we're working on pap smears among HIV-infected women, trying to increase those things, and going to Nigeria and seeing all the things we thought we have done here still present in Nigeria. So one of the things my career has focused on, apart from the infectious disease and the clinical part of it, is implementation science. So most of my funding come from NIH. They are mostly implementation science story. I'm not an oncologist. So my questions are not oncology-based, they're implementation science-based. So the first question I have is that I serve on a newly formed technical working group for elimination of cancer in Nigeria, which was established by the Ministry of Health. And we're trying to carve out some of the things to focus, to have a little bit of early wins and a little bit of low-hanging fruit where we can. So one of the areas that you mentioned, Dr. Khan, is when you talked about lung cancer and the challenges with screening for lung cancer in low-resource settings. So one of the things we did, we have a practice-based research network, which was one of the first things we established when I went back to Nigeria as part of the Nigerian Implementation Science Alliance. It is 12 sites, 2 from each of the geographical regions of Nigeria. And this was supposed to replicate what we did with HIV when we have sentinel sites to see what was happening with HIV. So we're trying to do those with cancers. So one of the things we are looking at those 12 sites is that we are trying to collect among those programs individuals who smoke. So we have a cohort of individuals who smoke at the 12 sites, which represent all the regions of Nigeria. Now we're thinking about what would be the most efficient way to screen for this. We don't have the CT scans in all of these places. Is there something else we can do? So that's my question to you. And I can go 3 of them first, or I can wait for you to answer.
Well, we want to give everyone a chance to ask.
Okay,
we'll
so I'll
take
ask one of
and
them,
then-
and I'll come back at it. Okay, thank you.
Thank you for all the amazing work you do. Really impressive. You know, I think in your population, you were saying that you have the smoking history and you're trying to identify how the cancer screening can happen.
Yes.
I would say perhaps, you know, utilizing the same screening guidelines that have shown improvement in outcomes would be, so anyone 50 to 80 years of age with the smoking. I guess the question is, like, besides the CT, low-dose CT scan,
yes.
is
What
there
can we
any-
use that we can actually implement?
I mean, I think none of the other strategies have been looked into. There are talks about these inhale tests and looking for, you know, genomic markers but I don't think anything has been proven to be beneficial. However, a good history and any high-risk symptoms would be probably the way to go. And then if there are patients with that high-risk history that is eligible and have some symptoms that might be concerning, those would be the patients I would refer out to where they can get the scan done. Because you know, many of these patients will have no symptoms for the early stage, but there will be a subset that will, and perhaps if the resources are limited, those would be the ones I would try to focus on. But unfortunately, no good answer here. I think these are places where a low-dose CT scanner, like the mobile scanners, would be something, and I know there are a lot of companies, pharmaceutical companies, that are investing in this. And I know at least one I can talk to you offline about that is really interested in international presence in these mobile scanners. So
Thank you. I'll come back when I give others a chance to answer.
Hi, I'm Heather. I'm from Genentech. Barbara, do you have any comments about cervical cancer in the Native American population, Alaskans and other Native Americans?
Well, it's certainly quite a bit higher. I mean, we do see a lot of racial disparities, and I think that's, again, sort of an access issue. I know, like, we have a program at Pine Ridge Indian Reservation in South Dakota, and, you know, it is the size of Rhode Island. It is the largest Indian reservation, and yet there is no OBGYNs who are present. So, and there are huge issues in terms of transportation, and so I think that is an access, and it's an implementation issue. We're also seeing very high levels of congenital syphilis because we just cannot get penicillin, you know, into the community. So I think there is an implementation problem on some of these reservations, and that is why the incidence rate is so high. It's also why I think that, you know, prevention is by far and away the most important thing we can do. And when countries, I think, you know, they prioritize prevention over screening, I think that is going to have a much, much bigger impact than the actual screening. And the fact that we've now been able to get away from cytology is so important. And we're really hoping that with the implementation of self-HPV screening and mail-in options, that is going to start to change the access issue.
So really working with like the tribal
Exactly.
leaders, getting
Yeah.
that, okay.
Yeah.
Thank you.
I'll throw up one for you, Hina, because I was thinking about how in the old days we learned that chest X-ray and sputum were not valuable ways to screen for lung cancer, but there is a lot of interest, obviously, in our field of lymphoma, circulating tumor DNA and colon cancer. Is there any kind of research going on right now about circulating tumor DNA, whether it's in sputum or in blood for lung cancer
Yeah.
screening?
Yeah, thank you for bringing that up. That's actually very interesting. So there are these MSATs, multi-cancer early detection assays that are ongoing, and in particular, there's a focus which started off with the lung cancer, and it's really ctDNA methylation patterns and other transcriptomic markers in blood. So there are studies that are ongoing. Actually, Brown is one of the premier sites that are starting one of those studies, and we are looking to see if these can be. I think the challenge is going to be number needed to treat. How many do you have to screen to be able to get that? So there's a lot of industry partnership that's required. Nothing that is,
Prime time.
yeah, in the prime time, but these are all studies that are undergoing. There are both lung cancer early detection assays and multi-cancer detection assays. I think the current ctDNA assays are more in the diagnostic space, in the therapeutic space, but in the diagnostics, it's really still evolving.
Thank you. Linda, you had a question.
Yes, so I'm Linda. I'm a pharmacist at Virginia Mason. Prior to being at Virginia Mason, I'd helped to launch an immunization program for Bartell drugs. And when you launch an immunization program, sometimes you encounter people who have vaccine hesitancy. And one of the things that I heard most frequently with patients regarding the Gardasil vaccine was, well, I don't want to think about my 9-year-old child being sexually active. So what strategies do you have around those kinds of conversations?
Yeah, I think the CDC has, really tried in terms of, I don't know if you've seen any of the ads that they have about, sort of thinking about, you have to think about it, right? You as a parent, it's all about protection, right? And so I think that's what the CDC has really launched when they have their ads on TV and their other campaigns, is it's about protecting your child and, and doing what you can. Like, you wouldn't let your kid get in the car without a seatbelt, right? Like, why would you let them get cancer? I mean, I think that's the strategy that we see. And what's really interesting is that with HPV vaccinations, those people in higher socioeconomic statuses are less likely to get the vaccine than people in low socioeconomic status, which I find just a very, really, really interesting thing. But, if COVID didn't teach us anything, I mean, now vaccines are political, right? And that's what's, and it's just very sad, because these cancers are almost 100% preventable. Yeah.
Thank you.
Hi, excellent talks. My name is Irene Tami. I'm an assistant professor at the University of Texas, and my question is to Dr. Debbie Aboulafia. 20 years ago, I was directed an HIV specialized dental unit, first of its kind in the country. I'm originally from Venezuela. I saw that you mentioned sarcoma Kaposi being so prevalent in low and middle income countries, but when I see the map, I see Latin America not having that many cases. I have a theory, but it's 20 years since I'm not practicing as a dentist. So I wonder if you have any new data on sarcoma Kaposi in Latin America. I guess that in our case, back in those days, was lack of reporting, because not too many dentists wanted to take care of patients diagnosed with HIV infection, but I'm eager to hear your experience.
I think I agree with your impression. I think there are real challenges in terms of reporting for Kaposi sarcoma. Many of the patients never get biopsies. They never get put into the cancer registries. We know that there's a lot of KS in Latin America. AIDS Malignancy Consortium now is heavily invested in Latin America, and they're the largest accruing sites for some of our KS studies. So yes, it's a big deal reporting. I think these maps are very underestimated across the world, but in particularly Latin America, Sub-Saharan Africa, huge gaps in reporting.
Thank you so much.
Sure.
Wonderful talk.
We have time for one more question.
I thought you were coming to the end of your 15 minutes, so I'm going to try to make it quick. I'm Terry Kuti. I have a local NGO, but global presence, so to speak, and it's in the world of breast cancer and breast reconstruction. And Hina, by the way, you guys brought so much thought process to me. And Hina, something that you said about awareness, access to care, the staggering statistic in lung cancer, that is what woke me up. So my question is, because this is what I do every day at my nonprofit, is bring awareness, bring access to care. How are all of you doing this in your space in the individual cancers? What other resources are we utilizing? Because you guys have full and busy lives. I have a background in education. I have no medical background, but took a full interest in doing this because of the need. So what resources are you guys using? And I'm just curious, your cancers that you talked about are outside of my realm, but yet the need for access, resource, and education is there. It's so important.
So important. Thank you for recognizing that. So I think lung cancer screening, that's the thing about it, is that I think it's applicable. The education awareness is applicable across the board. There will be breast cancer survivors or breast cancer patients that may also be smokers. There are family members oftentimes that I'm talking to patients who are smokers. So I don't hesitate to bring it up to even the people that come with my patients if they are smoking, to make sure they talk to their primary care providers about lung cancer screening. Because sometimes it takes as much as just a sentence, and they just don't know that they are eligible or it's covered by insurance, and it's just one scan. That they would, especially when there is someone sick in the family, I think that's sort of a higher chances that they would be able to. So I think all of us that are involved in the healthcare system, whether it's in primary care or even in nursing or medical, even the MAs are very critical in this, MAs in nursing, to identify, to talk about it, because it's awareness can be at any level. So please continue to talk to your patients and encourage them.
You nailed it. Sometimes it only takes one sentence.
Yeah.
That was perfect.
Well, you guys, I'd love to keep this going a little bit further. There's a lot to unpack, particularly when I was thinking about anal cancer screening, and the barriers and implementation for that is enormous. Maybe Don will have more to say about that. But this ends our first session. Thank you very much to our